Hello, I'm Dr. John Cruz, and it looks like Facebook has changed what it's doing a little, so I'm not quite clear whether this is broadcasting right now. So again, this is Dr. John Cruz. Facebook has again changed how it sets things up, so I might have just repeated myself. Today I'm going to be talking about, is ADHD overdiagnosed or not? I'll be talking for about 20 minutes. If you have questions while I'm talking, you can type them in, and this will be posted later on the Facebook page and on YouTube. So the simple answer is, of course ADHD is overdiagnosed. If we mean that, do occasionally people make a false positive, and by that I mean diagnose it when it's not really there. That happens for everything in medicine: heart attacks, cancer, Parkinson's disease. Occasionally we identify it when it's not really there. And there's also false negatives. So we miss it when it's really there. So we can make a meaningless categorical statement that ADHD is both overdiagnosed and underdiagnosed. But at a meaningful level, what we mean by that question is whether there is a pervasive trend in diagnosing lots of people who don't really have it and potentially treating them and exposing them to the risks of that treatment, or are we largely underdiagnosing it and missing lots of treatments and depriving people of the potential benefits of that. Or we could be hitting right in the sweet spot and making very few false positives or false negatives. Now, I'm going to share that my clinical bias, and that's just from the several hundred people I've seen in close to 30 years of doing this, we are grossly, wildly underdiagnosing it. I see people, a large proportion of the people who I see as new patients every year have had ADHD, and it was missed until I saw them or missed until later in life. And I've seen virtually nobody who came in with ADHD, a diagnosis of it, and it didn't seem to be actually the case. Now, part of my bias is that people who clearly didn't have it may run screaming from the mental health industry, if we call it an industry, or caretakers or treatment professionals. So my sampling is likely to be biased in that way. So today's discussion is focusing on one big article that got published in JAMA Pediatrics by Kazda and her colleagues very recently. It got a lot of media attention because its simple statement was that ADHD, we are substantially overdiagnosing it and overtreating it. I don't think they made their case even remotely in the article. So launching into what they did. So this was not actually new research, new going into the field and actually looking at people who are diagnosed with it and trying to determine whether they really have it or not, and or looking at people who aren't diagnosed currently and seeing whether they really deserve or merit a diagnosis. So this was not new research, this was meta-analysis of previous studies. Two, unlike what we were talking about either last week or the week before, which was, can ADHD suddenly appear in adults? And that issue clearly is tied into whether we underdiagnose it or miss it in children or not, or overdiagnose it in children. So this meta-analysis was only on studies that were done on children, young adults, 18 or younger, so much less relevance to the adult ADHD question, but tied in with it. And they actually did an extensive study trying to find all the relevant research done between 1979 and 2020, so a 40-year span of the ADHD publications. However, of the 12,000 plus studies that they came up with, they felt that only 2.5%, 2.7%, so 334 studies were pertinent to the questions they were asking. And they asked 5 different questions. The first one is, and they framed it this way, is there a reservoir of undiagnosed ADHD, particularly in the early studies? Were we missing it then? And it's strange they kept using the word reservoir of ADHD, and they even make a statement in the end that they're not trying to address the question of underdiagnosis. My claim is that this reservoir of ADHD that they found, and clearly the studies do support, we were missing it. supports that we've underdiagnosed it. So I'll jump through the 5 questions first and go. So 1, is there a reservoir of ADHD undiagnosed? 2, are rates of ADHD diagnosis increasing over time? 3, are the additional cases that are turning up in later studies milder cases? 4, is medication use increasing in the treatment of ADHD? And 5, are we assessing the harm that may come from treating these milder cases and considering the possibility that the harms might outweigh the benefits? So we'll go through each of these questions they feel, and they didn't come up with these criteria. These criteria have been applied for other conditions, particularly cancer treatment, and there is, again, a question on, certainly with certain tumors and growths, what divides cancer from other tumors. I won't get into that issue, but it highlights that it isn't just psychiatry and mental health that have trouble deciding where the boundary lines often go. So the first question, again, was looking at, is there a reservoir of undiagnosed ADHD? And most of that work was looking at, can we find discrepancies, for example, between boys and girls, between minority groups and lower income socioeconomic groups, and at the same time in place, or between different racial groups, where we can't come up with any compelling biological reason. I mean, we may be able with gender, but less so with race or socioeconomic status, why we would see these discrepancies. And the discrepancy in diagnoses would suggest that we are missing substantial diagnoses. And again, this was more prevalent in the early years that they were studying. And again, their conclusion was quite robust, that there was, and maybe still is, some reservoir of undiagnosed ADHD, again, particularly maybe in women, particularly inattentive type ADHD, particularly in certain minority groups that may have less contact with mental health professionals. And again, although they don't frame it this way, I would say their answer to that question is saying, we have, to me, it's you can't avoid it. That's saying we are underdiagnosing ADHD still to this day, more so in the past, but that they're definitely documenting underdiagnosis of ADHD. So second point, are the rates of diagnosing ADHD increasing? And pretty consistently, maybe not absolutely perfectly every study, but very strong trend, yes. And again, that's a support suggestion that we may be leading to overdiagnosis, but there can be a couple of different reasons why we're picking up more cases of ADHD. So one possibility, which tends to get dismissed out of hand, and lots of the ADD community researchers don't even want to consider it, that possibly we're experiencing a true increase in ADHD. Why the field doesn't want to look at it or even consider that is that they feel that it may sort of delegitimize the standing of ADHD as a true, legitimate, biologically based neurodevelopmental condition. I don't think that finding an increase in rate would do that at all, because for all of our conditions in mental health and physical health, it's always an interaction between nature and nurture. It's always both the social environment and the physical, somatic, bodily environment that are leading to issues. And it's funny that in mental health we have no problem with claiming, oh, PTSD has gone up hugely during COVID, or even rates of depression or anxiety have gone up during COVID. Well, we know there's a biological basis for depression, anxiety, PTSD. Again, with PTSD, its diagnosis clearly tied into social and environmental factors. But with these conditions, we have no problem saying if the world changes, we may be getting more of these mental health problems. Well, in the last 40 years, the world has changed. And as the third of my book, Recognizing Adult ADHD, goes into, the first 2/3 were largely Trump-oriented, but the last third is talking about how our whole world has become more ADHD-ogenic in terms of we're being thrown much more information, communication, electronic exposure, and asked to respond to it quickly, superficially, without depth, sort of impulsively. I'd argue that that's pushing us in ADHD directions. Sleep trends continue to, we tend to be an increasingly sleep deprived, particularly in Western industrial countries. Amounts of exercise continue to decline. Diets continue to get worse. All of those measurably in studies seem to increase ADHD symptoms, and as part of the feedback loop, if you have ADHD, you indulge in each of these, I'll just label them, I know it's pejorative, bad behaviors, which again tend to feed the feedback loop. So I wouldn't be surprised if there is a real increase in the incidence of ADHD, or we're finding it, because there is more ADHD out there. Separate from that, two other possibilities. One is that we've just gotten better at detecting it, and there's certainly an element of that, particularly, again, when I was in training, there was no general clinical acknowledgement that adults could have ADHD, so finding it much more in adults now than we did 40 years ago is not surprising. People are looking for it. People are using scales to assess it and measure it, and we're detecting it. It was there 40 years ago. We just weren't detecting it. And the other possible explanation for increase, and this is much more tied into are we overdiagnosing, is sort of the concept of diagnostic creep or diagnostic inflation, kind of like grade inflation. And that is, have we loosened the criteria? Have we broadened our concept so that we are picking up people who have milder parts or conditions of milder symptomatology of ADHD, and maybe we shouldn't really change where our boundaries are for this condition. Maybe we are encroaching on what is just normal. And that's a good and important question, which should be an ongoing dialogue, and nobody has a definitive answer for, but there is evidence of diagnostic creep. So I'll get into that. That's sort of the third point. Actually, what I'll say a little bit is that in this CASDA article, there's a strong, and it's clear in the writing, bias that it is bad to pick up cases that are milder. They also pretty clearly identify that the way of detecting severity is with our scales that measure symptom severity, and even though people far brighter than myself have spent whole careers coming up with scales for measuring ADHD or depression or OCD, we do a horrible job of measuring that in psychiatry. I mean, part of it is probably good in that some of this isn't measurable or reduced to numbers or monetized, as the MBAs want to turn everything into. And they sort of fault that in some of the studies that they use measures of impairment rather than measures of severity of symptoms, and I would argue that in many cases impairment may be a better marker of ADHD or measurement of ADHD severity than checklists saying, are you frequently late to things, do you interrupt people? And I'll just sort of go into an example of that. On some of the scales, a commonly asked question is, are you late? And if you have ADHD that, let's say, is mild, say you are always punctual and that doesn't, you don't meet that criteria, okay. But for that criteria, say you're 5 to 10 minutes late for work, you're 5 to 10 minutes late for social events, you get a check mark, you get the full tick mark against you for that variable, for that severity. But let's say Joe here has really bad ADHD, he's always 2 hours late for work or 2 hours late for social appointments. This scale is measuring them both as, lateness, check. Again, our scales are so lousy in psychiatry in capturing the depth, severity, impairment, real life meaning. It's not that there's no use in them or no functionality, but they are so poor at measuring disease severity. That's my bias anyway. And I don't think, there's been a huge push to using more and more of these checklists. I don't think using them more makes them better. It makes it so we can do studies where we're comparing things, but if we're comparing things that may be missing the essence of it, so I won't go down that too long right now. So their study suggested that very clearly, yes, we are picking up more milder symptoms. So that was the third thing they were testing for. Rates are increasing, but part of that increased rate is that we are picking up more milder cases. And one of the problematic aspects of that is, and I think this is probably their best example of overdiagnosis, or where we are picking up or assigning the label to people who don't deserve it, there's now many studies looking at within a classroom, within a school group, that kids who are the youngest in their classroom are much more likely to be diagnosed with ADHD than kids who are at the old end of the spectrum. And yet theoretically, built into the ADHD diagnosis is you are supposed to be comparing, if you're deciding the kid is interrupting too much, talking too much, not sitting still too much, you are supposed to be using an age-matched control. You are supposed to be assessing whether this is inappropriate for their age, not inappropriate for their classroom or school grade. So that's an area where there's clearly diagnostic creep, and people, particularly some younger kids, are being thrown into that pool because they are more immature, not because they really have ADHD. So there's meta-analysis found that yes, there is more cases, milder cases we're picking up. They also did document that increasing percentage of people who have ADHD are being treated, including being primarily they were focusing treated with stimulant medication. And that again, they sort of suggested is a bad or an evil thing. Nowhere, and I haven't double, triple read it, could I find any reference? We do have more than 30 studies done almost all in children looking at kids with ADHD who were treated with stimulants compared to ADHD kids who received no treatment. And by the end of adolescence, all of those studies have found more normal looking brains in kids who received the stimulant medication. So they sort of ignored the possibility that we are maybe foreordaining or pushing some kids into a lifetime of ADHD who might have escaped it by having, there may be actually definitive treatment for some of these kids through use of ADHD medications in youth, even though, again, the majority of people treated in youth do still have ADHD as adults and do continue to benefit or need medication. So the fifth point was, whether studies are accurately looking at whether the costs of treating particularly these milder cases outweigh any benefits of treating these milder cases. And although their conclusion is yes, they've shown that, their summary of discussing these things is that it's a maybe. There's no studies they cited which definitively showed that costs outweighed the benefits. They simply did not show that. One is it's hard to quantify costs versus benefits, or are you going to count the number of people harmed? And again, it's getting into the severity. I mean, how messed up, it's hard to measure how messed up someone could be. So getting into some of the costs or some of the benefits they do identify of diagnosing the ADHD is, we know in treating it is improvements in academic performance, decreased drug use, increased healthiness in terms of fewer accidents, fewer motor vehicle accidents, and psychological benefits are many people benefit from understanding, okay, I have ADHD, I'm not just lazy, I'm not just being rude, I'm not just being inconsiderate, I have problems with attention problems, reining in my impulses problems, with executive functions controlling myself at times. Another psychological benefit that of gaining a diagnosis is increased sense of control. So if you can identify, oh, this is because of my ADHD, I can either work with solutions, medication, or finding greater structure, asking for more reinforcement, or practicing the hell out of scheduling or certain traits, or learning to declutter your environment. You can gain a sense of control from receiving that diagnosis. There's also studies supporting increased sense of self capability from receiving a diagnosis. Again, that it may be better than being told you're stupid or slow or missing the boat all the time. And the other big area of benefit is that with a diagnosis, you're getting potentially more support and more tailored, precise support, again, whether that's in classrooms or workplaces or at the home environment, so you can thrive. The costs they identified for identifying it in people who may only have very mild cases is that rather than being, again, used as an explanation for what's going on, people can start using it as an excuse. Oh, I have ADHD. I don't need to turn my homework in because I have ADHD, so I'm not going to do it. So that they also identified as being tied in with a loss of control or a pattern of helplessness or passiveness. That, if I have ADHD, there's no point in trying because I'll never do as well as Billy over there on the chemistry test or something like that. And along with that, it can lead to self-blame. If you have a label to stick on yourself that particularly if it is, and that's getting the last point, it's stigmatized or made fun of, then you may think, I'm bad because I have ADHD. I would argue that in most of our society, that the stigma attached to the label of ADHD is less than being called a moron or retarded or rude or selfish or half the labels that a certain President Trump was called, which when we were describing behavior attributed to his ADHD, it would be less stigmatizing to say that's ADHD than a host of things he would call. So again, my summary is that this meta-analysis confirmed solidly that yes, we have underdiagnosed ADHD, particularly in certain populations, and they've documented clearly, yes, there have been increases in diagnosis and increases in treatment, and they showed very weak support for the claim that we are overdiagnosing or overtreating, that this is inappropriate or harmful. They raised potential that there could be harm in some individuals, but I would argue what they presented certainly did not show systematically that is occurring. That's about all for today. I can make one additional point. Some of this confusion as to whether we're missing cases or not. I have a colleague who at every ADHD presentation or meeting would bring up the same point. He's both a child psychiatrist and adult psychiatrist, and he said, why do all the adults that I treat with ADHD sort of crave or want or, love their medication, take it pretty consistently and want to be on it, while all the kids he's treated with ADHD, rebel against it, don't want to take it, hide it, cheek it, are embarrassed of it, avoid it, and yet measurably both kids and adults benefit from these drugs. I can go into that in another time, but that highlights individuals can have different attitudes or more awareness of how their differences may be impairing them or affecting them, and whether medications are truly helping them or adding additional problems. So I am not seeing again any questions. If you have any later, I'm happy to address them, and I'll be signing out. Next week's topic is going to be on the brand new FDA-approved non-stimulant for ADHD called brand name Qelbree with a Q, and its generic name is viloxazine. That will be next week's topic. Stay safe and be happy.